Good morning, everyone. Thank you so much for being here for this educational session and informational presentation on women's healthcare workforce challenges in Idaho. I'm Susie Keller. I'm the CEO of the Idaho Medical Association, and I'm joined by Brian Whitlock of the Idaho Hospital Association. We're just here to talk about the challenges we're having with workforce and its impacts on patient access to care. Unfortunately, Idaho's abortion laws make it difficult, if not impossible, for physicians to take care of some pregnancy complications that could affect a woman's future fertility or her health. The law only allows physician intervention to prevent the death of the patient. And this has caused a great deal of uncertainty and fear among both physicians and patients. So today you're going to hear from members of Idaho's medical community who are on the front lines, physicians, hospital administrators, even a colleague from the health insurance industry, about how they are trying to move through this evolving legal landscape. We're going to try and move through all of the speakers and then leave time for a couple of questions at the end, depending on time. We're going to try and wrap up within the hour, if at all possible. So before we dive into the Idaho perspective, Brian's going to share some insights from the national side of things.
Thank you, Susie. Good morning. I'm Brian Whitlock, President and CEO of the Idaho Hospital Association. We advocate for state policies that protect Idahoans' ability to access the right care at the right time, in the right place, and at the right price. But we also have to acknowledge that we are in competition, fierce competition nationally, for a workforce to take care of those healthcare needs here in our state. Just last month, there was a study released by the Association of American Medical Colleges that said by 2036, nationally, the United States will have a shortage of 86,000 physicians. So I imagine that there are probably 49 other legislatures across the country that are having similar conversations about their current healthcare workforce and what they need to do to ensure that their citizens have access to care in the future. Here in Idaho, as we contemplate the healthcare needs for one of the fastest growing states in the country, we unfortunately begin those conversations and discussions from a deficit standpoint. Idaho is 45th for actively practicing primary care physicians, 49th for actively practicing physicians of all types, and 50th for actively practicing general surgeons. If any of you here today have tried to get in to see a specialist lately, whether it's an oncologist, rheumatologist, orthopedic surgeon, or OBGYN, the wait time may not be weeks, it could be months. So let me just take that last specialty that I mentioned, OBGYNs. The Idaho Hospital Association surveyed all 51 of our member hospitals across the state, large and small, to better understand the difficulties that Idaho women are having getting in to see OBGYNs. We saw a doubling, and in some cases a tripling, in OBGYN vacancies in our hospitals from June of 2022 to June of 2023. It is now taking 2 years or longer to find someone to fill those positions that are vacant. And if you think back to that national backdrop that I just talked about, where there is already fierce competition nationwide for practitioners, Idaho is seeing that the pool of applicants for OBGYNs, considering a position here in Idaho, has decreased by a third to a half of what hospitals traditionally saw, if those hospitals have any applicants at all. Our member hospitals are telling us that it's not only the competition that has created vacancies, but also a lack of interest in filling those vacancies. Hospital administrators are telling us that the lack of clarity in Idaho's legal environment regarding maternal health care has created uncertainty and fear, and candidates are now looking elsewhere to practice.
So what does this mean for patients? Women who want to start or grow their families are feeling uncertainty and fear as well. Please direct your attention to this video I'm going to share with you, and it features real Idaho moms and dads who are trying to navigate this new environment. The video was produced by Idahoans for Healthy Moms, which is a broad-based effort to bring greater awareness and understanding to the public about Idaho's laws.
Unfortunately, Idaho has started to feel like a much less safe place to raise a family.
We had unintentional loss, which is labeled as an abortion in all of your medical paperwork. A lot of the statistics that they give are often people like me who really wanted a child for over a decade.
Making decisions, life and death decisions with people, it simply cannot be put in little black and white lines of print in a law.
I was entering a judgment zone and not something based off of my health and not based off of the science and the fact that we had a non-viable child.
If it was, not developing a brain and the doctor said to us, I hate to give you this news, but we're gonna have to have a termination because this child that your wife has inside of her is not going to be alive.
We are very grateful to those individuals who were willing to tell their stories. And unfortunately, there are many, many more Idaho families that are going through these heartbreaking situations. Now I'm going to shift our focus back to the physician workforce and what we're seeing, dive into some data. In February of this year, the Idaho Physician Wellbeing Action Collaborative compiled data into a report that was published by the Idaho Coalition for Safe Healthcare. And this report shows that unfortunately between August of 2022 and November of 2023, we've lost about a quarter of Idaho's OBGYN physician workforce. So using publicly available data, the report shows around a little over 50 OBGYNs, about 22% of those women's health physicians, have either left the state or retired from practice. So now we're at about 210 OBGYNs. During that same time frame, Idaho lost 5 of our 9 maternal fetal specialists. Those are folks that take care of high-risk pregnancies. So we lost over half of those folks during that same time period. In 2018, HRSA determined that we should need about 250 OBGYNs to take care of our population. By 2028, it says we are projected to need about 275. Again, right now we're at 210. That puts us at a ratio of 2.2 OBGYNs per 10,000 women in the state of Idaho. And just for reference, the national ratio has been about 14 to every 10,000 women. So unfortunately, Idaho is digging itself into a workforce hole that will take many years, if not decades, to fill. But before we can stabilize the environment and move forward, we have to stop digging. And we need more clarity in our laws to help with that. And now Brian's going to talk about how some of these physician losses are impacting the hospital staffing situation.
I think given the financial situation that many hospitals across the country are facing, you're seeing hospital closures as well as the closure of service lines. In 2023 here in Idaho, we had 2 rural hospitals, one in Sandpoint and the other in Emmett, announce the closure of their labor and delivery departments. We'll hear from one of those hospital CEOs in just a few minutes. And then this year, a larger hospital, one in Canyon County, just closed its labor and delivery and its neonatal intensive care unit on Monday. We are seeing the expansion of what's called obstetrical deserts here in Idaho, where pregnant mothers may need to travel long distances either for prenatal care or for the delivery of their baby. In Salmon, Idaho, which is home to the most remote hospital in the lower 48 states in the United States. Let me say that again. The most remote hospital in the lower 48. They've had to pause their labor and delivery services because they don't have a physician capable of doing that. So what are they doing in a community that is 94 miles away from Hamilton, Montana, and 168 miles away from Idaho Falls? If you're pregnant and living in one of those counties that's serviced by Steele Memorial Hospital, they are now encouraging you to establish a relationship with a doctor 94 miles away or 168 miles away for your prenatal care and for the delivery of that baby. They are actively recruiting an OBGYN or a family medicine doc that can come to the community, but we don't know when that actually will take place. In the meantime, if you have an emergency, go to the hospital. They will stabilize you, but you likely will be transported 168 miles away to Idaho Falls for the delivery of your baby. I'll turn it back to Susan.
And now we have an opportunity to hear from some of those physicians on the front lines of taking care of Idaho women and families. So I'd like to first introduce Dr. Sarah Thompson. If you would like to come up, she is a practicing OBGYN in Boise. She's a graduate of the University of Idaho and the Uniformed Services University. She began her medical career in the U.S. Army with 11 years of active duty service, including deployment to Iraq. Thank you for your service. Please go ahead.
Good morning. Thank you all for being here today. As Susie said, I'm Dr. Sarah Thompson. I'm an OBGYN practicing here in Boise, and I'm representing the Idaho section of the American College of Obstetricians and Gynecologists. I'm going to talk today about the problem with Idaho's laws from an obstetrician's perspective. This is a difficult subject to tackle, but one that needs our collective attention right now. We've had significant attrition in our obstetric workforce in Idaho, as Susie just mentioned. Between August of 2022 and November of 2023, we've lost 58 of 268 obstetricians in our state. And in that same time period, only 2 obstetricians moved to Idaho to practice. As my colleagues move out of state or retire, we've had difficulty replacing them. Idaho has no OBGYN residency programs or fellowships, so we cannot recruit new OBGYNs or maternal fetal medicine specialists from within our borders. Out-of-state applications to open positions have decreased dramatically. I've also spoken with traveling physicians called locum tenens who are reluctant to come to Idaho for assignments because their insurance only covers medical malpractice and not criminal liability. Some of you may wonder why our current laws are so challenging for those of us taking care of pregnant patients. If you think of a straight line with healthy being on one end and death on the other, sickness is somewhere in the middle. And as physicians, we're trained to intervene when we recognize sickness, not to watch an illness move along that line until death approaches. Waiting is bad medicine and can be malpractice. There are so many examples in medicine where timely intervention is critical to having a good outcome. Most people know that receiving timely intervention for a stroke or a heart attack is critical. Similarly, timely treatment for a pregnancy emergency is also critical. And this is the problem with Idaho's abortion law. We only have an exception to prevent death of the mother and not to preserve her health. I've heard our elected officials share opinions about the need to save both the baby and the mother, or that saving the life of the baby is a priority over the mother. I want this audience to understand that this is a false choice and is often not possible in situations we encounter in clinical practice. With many pre-viable pregnancy emergencies, the baby's prognosis has already been set into motion by the natural complications of the pregnancy, and the baby is going to be lost no matter what we do. The baby is too small to survive without the mom, so leaving the mother in a perilous situation for a few more hours or days, waiting until we can declare her situation life-threatening, does nothing to benefit that baby and only harms the mother. For example, if a pregnant woman's water breaks early in the second trimester, the baby is almost certainly going to be lost and not survive to a gestational age where life-saving resuscitation is possible. Many people would consider this a miscarriage in progress and not an abortion from an ethical or religious perspective. But in Idaho, if the baby still has a heartbeat, inducing or augmenting labor is legally considered an abortion. The national standard of care, however, is to offer immediate delivery in this situation because of the serious risk for hemorrhage, infection, and sepsis that can occur if the pregnancy continues. Unfortunately, these difficult situations where the law is in conflict with the standard of care are not hypothetical nor rare. In my practice, my group has been faced with a clinical situation where the law complicates care every month or two since Idaho's abortion law went into effect. Now, in addition to counseling patients about devastating diagnoses, we talk to attorneys, we talk to administrators, and we have complicated discussions with our patients and their families about the state law, and their care is delayed. And we feel conflicted about these cases for weeks afterwards. These situations haunt our sleep. If we delivered the patient, we fear being charged with a felony, and if we didn't treat the patient in accordance with our professional standards, we worry we violated our professional ethics by making a decision that is self-protective rather than in the best interest of our patient. And because of this moral conflict we're experiencing while caring for our patients, some of my OBGYN colleagues have left the state, and more are thinking about leaving if Idaho's laws don't change. Many of us have had a crisis of conscience about what to do, feeling both deeply committed to our patients, but also concerned about what this means for us personally and for our own families. The threat of incarceration for 5 years for patient care is a heavy burden. And being told that no physician in our state has been prosecuted yet, or that a case of medical necessity is unlikely to be prosecuted, is not adequately reassuring. If those types of cases are not likely to be prosecuted, the law should be updated to reflect that. Obstetricians don't want to be in a situation where we are having to test the boundaries of the law or perform acts of civil disobedience to protect our patients. Like most people, we want to be legally secure in our work. And that's hard to do right now because the laws were not written in a way that compassionately considers some of the pregnancy complications that we encounter. And for those of you with religious concerns about changing the law, especially to my fellow Catholics, please know that Idaho's current abortion law is more prohibitive of care than what is permitted under the ethical and religious directives for Catholic health services published by the U.S. Conference of Catholic Bishops. I want to conclude with a patient story. Savita Halapanavar was a 31-year-old dentist in Ireland. In 2012, she presented to the hospital in the 17th week of her pregnancy with abdominal pain. Her cervix was dilated and amniotic membranes were in the birth canal. She was admitted to the hospital and her water broke the next day. Despite Savita's and her husband's pleas to end the pregnancy, she was not delivered, as abortion was illegal in Ireland at that time unless it was to save the life of the mother. During her hospitalization, the baby was ultimately stillborn, and Savita died of sepsis. An investigation of her care showed that a lack of legal clarity about when a termination of pregnancy was allowed contributed to her death, and that is exactly the problem that we could have in Idaho. No matter what the U.S. Supreme Court decides about federal law versus state sovereignty later this year, we need a maternal health exception to our Defense of Life Act. Idaho mothers have already suffered from serious complications as a result of the law, and we should not wait for a maternal death to happen here before we make changes. Being able to care for our patients safely without the threat of criminal repercussions could help stem the loss of our OBGYN workforce and ensure that there are enough of us left here to care for the pregnant citizens of Idaho. Thank you.
Thank you, Dr. Thompson. Next, we have Dr. Lauren Colson. Dr. Colson is a family medicine physician practicing here in Boise. He's a member of the IMA Reproductive Health Committee and co-president of the Idaho Coalition for Safe Healthcare.
Thank you everyone for being here, for taking the time to hear from members of the Idaho healthcare community with the current healthcare workforce issues that our state faces. As Susie said, my name is Lauren Colson. I'm a family physician who practices full spectrum care including obstetrics, pediatrics, adult, and hospital medicine. I'm involved in state professional organizations such as the Idaho Medical Association and the Idaho Academy of Family Physicians. And I'm the co-chair of the Idaho Coalition for Safe Healthcare, an organization comprised of nearly 900 Idahoans dedicated to safe, legal, and equitable access to evidence-based medical care. Today, I would like to discuss with you a family physician's perspective on Idaho's healthcare workforce issues. Idaho has a unique landscape when it comes to practicing medicine. Given its dispersed population in large rural areas, the Idaho physician workforce relies heavily on family medicine doctors to provide comprehensive care in many of its communities. In particular, family physicians in Idaho provide obstetrical care at a rate higher than the national average. I'm proud to work in a state that supports my practice of obstetrics as a family physician, though I feel this feeling of support is fading. The current abortion laws in Idaho make me second-guess my decisions, and that can lead to harmful outcomes for patients. Many complications arise very early in pregnancy, and unfortunately, many of these complications mean that the fetus will not survive, will ultimately end in miscarriage. In fact, about 1 in 10 women will have a miscarriage at some point, and miscarriage for any pregnancy is around 15%. Despite this being common and there being some protections in the law for managing a miscarriage, there remains a lack of clarity that can lead to a delay in care and unnecessary procedures. While I may have previously relied on an ultrasound confirming miscarriage by one of my colleagues, I now repeat an invasive transvaginal ultrasound on any patient to whom I will be providing miscarriage management. I have to heavily document my findings, which creates an additional administrative burden. If I decide to do a procedure in clinic, I have to ensure that all of my support staff are aware, as they could be prosecuted under the abortion ban for assisting in an abortion should someone decide to take me to court. If I decide to use a medication to provide miscarriage management, I have to ensure that the pharmacist is willing to dispense the medication. I know this last part from a personal experience when a pharmacist refused to fill my wife's medication for her miscarriage. And while I may feel like I can provide most miscarriage management to the patients who qualify under Idaho law, many of my colleagues do not feel comfortable with this given the risk of prosecution or imprisonment. In these situations, Idahoans who are miscarrying could need to travel to the nearest physician who does feel comfortable providing this type of care, which could be hours away. Another example that family physicians often deal with is when performing intrauterine procedures, such as the placement or removal of an intrauterine device, or IUD. Family physicians provide a large part of birth control services here in Idaho. I had a patient who needed an IUD removed when she found out she was pregnant, and she had to go to 2 other providers before coming to me due to concerns of accidentally ending pregnancy with the removal of the IUD. And this isn't an isolated incident. I've heard similar stories from other physicians concerned about removing IUDs in a pregnant person over fear of causing that pregnancy to end, something that could be perceived as an abortion by somebody else. However, if the IUD is not removed, that patient carries a higher risk of miscarriage and infection through that pregnancy. For family physicians who provide obstetrical care, we rely heavily on our OBGYN colleagues and maternal fetal medicine specialists to safely provide obstetrical care. For example, I am trained in vaginal deliveries, and while some family physicians are able to provide cesarean sections, many are not. Furthermore, I am trained to manage basic pregnancy-related complications. However, for many conditions, I consult my trusted OBGYN and MFM colleagues to help manage these patients safely and with the highest level of care possible. Once a person is further along in their pregnancy, as many of you have heard through various testimonies, there are many complications that require co-management with an OB or MFM doctor. But now, with about 22% less OBs practicing and less than half of the amount of MFMs than were here a year and a half ago, it can be harder for us to find an OB or MFM to consult with. This leaves us as family physicians with less expertise in managing complex obstetrical cases. We're left to figure it out on our own. When this occurs and we feel unsafe, we have 2 options: provide less safe care or transport these patients out of state. I can't provide exact numbers today, but I know that we have seen an uptick in the amount of patients who have been transported out of state for pregnancy-related complications over the last year and a half. If we keep going down this path, we are certain to see a downtrend in the family physicians practicing reproductive care and obstetrics in Idaho. And that's a terrible thing, because these same family physicians aren't just providing OB. They're providing regular checkups, Medicare visits, pediatrics, emergency care, and hospital care. If they are prosecuted, regardless of whether they get convicted or not, they have to shut down the practice or find someone else to cover them while they're in court, which could ultimately lead to financial ruin and the shuttering of their clinic doors. This is not what family doctors want. This is not what Idahoans want. We need to protect our family physicians so that they can keep caring for the communities they love dearly. We need to enact changes to our current abortion laws to make physicians once again feel welcome here. As you've heard today, we have proposed solutions to the legislature. At the very least, an exception in the case of serious health risks would allow physicians to feel safe practicing most obstetrical care. We wouldn't have to live with the fear of being prosecuted every time we take a pregnant person on and then they develop complications. So please contact your legislators and tell them to hear us. And if you're a legislator, please consider our proposals so that we can stabilize the healthcare workforce in Idaho. Thank you.
Thank you, Dr. Colson. Next we have Dr. Megan Casper. Dr. Casper is an OBGYN practicing in Canyon County. She represents District 3 on the IMA Board of Trustees, and she's the chair of the IMA Reproductive Health Committee. Dr. Casper.
Thank you, Susie. Thank you all for being here to hear from us as we take care of Idahoans in Idaho. As Susie said, my name is Megan Casper. I am an OBGYN and I practice in Nampa. And I'd like to share with you some of my experiences practicing here in the Treasure Valley. A recent patient that I took care of was a young woman who came in her second trimester of pregnancy. She was still several weeks away from the minimum viable gestational age at which we can intervene to resuscitate or care for a premature infant. She was having painful contractions and her cervix was already 5 centimeters dilated. I admitted her and cared for her. Expectant and supportive care is what we can offer in that situation. And it was an interesting situation for me because my care of that patient did not change based on the change of laws that went into effect in August of 2022. But the things that I needed to manage in the background were different. What did I need to do to keep myself and the whole healthcare team out of trouble? As a physician and the leader of the healthcare team, I'm not just responsible for myself, I'm responsible for the nurses, respiratory therapists, the whole care team. What was going to be my threshold for her health status? If she started bleeding, how much bleeding was I going to tolerate? At what point would her bleeding be enough that I would feel confident saying, okay, this is life-threatening? Under normal circumstances, this was a baby who was not going to survive this process. And so I would, as a physician, not have a whole lot of room for anything going the wrong direction. I would say, all right, this is starting to go not well. We need to step in and intervene and keep you miles away from anything life-threatening. But now I have to think about that, and I have to have parameters that I know I can support potentially in court. But also interestingly, these kinds of things, getting in trouble for doing the right thing for my patients, that is not something that keeps me up at night. For me personally, that part's okay. What has started to keep me up at night is the evolving maternity care desert that I now practice in the middle of. I work in Nampa in Canyon County, and the state of Idaho is divided into 6 health districts, and the 6 or 7, sorry. The health district that I'm in has 6 counties. Canyon, Owyhee, Payette, Gem, Adams, and Washington. And for that population of reproductive age women in that health district, we should have, at a minimum, 30 to 40 OBGYNs. We currently have, depending on how you count it with some part-time people, we have 11 to 13 FTEs of OBGYNs for that population of women. That's also a health district that's seen the closure of 2 labor and delivery units spread out over a relatively significant geographic distance in the last couple of years. I continue to work in that area, but watching this evolve in front of me is very sobering. We're doing what we can. We're seeing more patients. We're managing the high risk, the low risk, trying to be very thoughtful about how we're doing that. But it does kind of keep me up at night. At what point does this break down? At what point are we just not able to keep up with the healthcare needs anymore? And this is not rural Idaho that I am talking about. This is right here in the Treasure Valley that we have this developing maternity care wizard. As we move forward, it has become very clear to me that the current situation here in Idaho is no longer about pro-life or pro-choice camps. It's about basic maternity care that no one in 1972 even thought about questioning. This is about the state of Idaho standing up and saying, yes, we want to protect Idaho moms, babies, families, citizens, and we want to make it very clear to Idaho healthcare providers, physicians, midwives, nurses, this is what we want you to do. This is the care we want you to provide. We want you to show up and keep women, babies, families safe. Thank you.
Thank you, Dr. Casper and Dr. Thompson and Dr. Colson. Appreciate that. Dr. Jim Souza stands tall in the healthcare community, literally and figuratively. I have to raise this for him. He is the chief physician executive for St. Luke's Health System, and we've asked him to share his perspective on the impacts that and challenges that Dr. Colson, Dr. Thompson, and Dr. Casper have discussed, and what those impacts are having across the healthcare spectrum and infrastructure in our state. Dr. Souza.
Thank you, and thank you all for being here and for your interest. I'm a pulmonary critical care physician and serve as St. Luke's chief physician. In my role, I oversee the physician enterprise, and I'm accountable for improvement in and maintenance of our systems of care. It's really important as I begin my comments on systems of care, that's my focus, to understand the importance of them. Only 124 years ago, when many of our grandparents and certainly our great-grandparents were alive in 1900, the average human life expectancy in the United States was 47 years. A significant amount of that early mortality was due to the 10% plus rate of death for children within the first year of life and the 1% rate of death for moms during labor and delivery. A quick tour through any turn of the century cemetery will prove this to you. In the span of just 100 years, we humans have added more than 3 decades to the human lifespan. And we've done it through a combination of public health interventions and medical science. The medical science interventions have included vaccinations, antibiotics, new therapies, surgical techniques, transfusion medicine, and the explosion of interventions to rescue people from catastrophic presentations like stroke, heart attack, trauma, you name it. These medical science interventions are delivered through a complex system of care that depends upon providers to provide the care, innovation and research to develop new treatments, industry to produce those treatments, healthcare systems to deliver those treatments, and a regulatory and oversight structure to make sure we're moving in the right direction. All of these parts and pieces are highly interdependent, which brings me to the topic at hand today. After decades of advancement in the safety and efficacy of women's health care, we're seeing a significant degradation in that system. This will predictably, this is not rocket science, lead to increased complications for women and their children. We know this. Greater need for rescue services. We know this. Increases in the total cost of care. We know this. Increases in the permanent loss of reproductive function and impacts to the health of mothers, and for some, increases in our maternal mortality rate. The primary factor which is destabilizing the system of care today is the physician and provider workforce. You can think about the workforce in this area like a pyramid. I've used that metaphor before. And at the base of the pyramid are certified nurse midwives and family physicians who provide much of the care in rural communities and in urban communities as well. Above them are the OB/GYN specialists, the doctors who are trained to manage low and moderate risk pregnancies and who care for the health of the reproductive organs. And then at the top of the pyramid are the maternal fetal medicine specialists who are trained to manage high-risk pregnancy and pregnancies complicated by fetal anomalies. We're seeing significant changes in recruiting and retention. In recruiting, positions are remaining open for months that were previously filled in weeks, or they're just not getting filled. There are practices now more than 12 months without an interested party to accept that position. On retention, we've heard today that the small number of maternal fetal medicine specialists we had in the state dropped by more than 50% in 1 year. We were already behind. We still didn't have enough, and it will take years to recover from this setback alone. And this is where the system of care comes in. The maternal fetal medicine doctors are the safety net for the system of care from the provider perspective. They are the reason that we can manage a high-risk pregnancy from literally 100 miles away and carry it off safely. As that core team of maternal fetal medicine specialists has been leaving and we've been struggling in recruiting, family physicians and OBs across the state are asking if it's still safe, personally and professionally, to be providing obstetrical care. We've already heard some of the facts about the losses that we have seen. As the providers go, so too go the labor decks. Since August of 22, when only 22 of Idaho's 44 counties have a labor deck, that has fallen now to 20. Women in these areas will now need to travel to get perinatal care. And to the degree that they can travel, they won't get that care. And to the degree that they don't get that care, we can predict that they will have increases in perinatal complications like poorly managed gestational diabetes or preeclampsia. Again, not rocket science. We know this will happen. There will be a significant increase in these complications. That will lead to more high-end, costly transports to centers like the one I lead. And some of those rescue attempts will end in complications, which may be lethal and more likely will be associated with permanent impacts on maternal health and maternal reproductive capacity. Even a 15-mile increase in the distance a woman in an emergency has to travel delays an urgent intervention where seconds count. Imagine what 100 miles does. Finally, the system of care impacts within the maternal and perinatal space, because of the interconnectedness of healthcare delivery systems of care, leads to other impacts, particularly in rural areas. When a labor deck closes, it puts at risk other services that were possible because of the presence of the labor deck. One example would be a critical access hospital that does surgical procedures. The administrator of that hospital, at the loss of the labor deck, has to ask and answer the question, do the numbers still pencil out for me in volumes to be able to carry out surgical procedures now that half of my volume is gone because I no longer deliver babies? An even more chilling outcome that we can and should be anticipating is erosion in the primary care base in rural communities. Doctors like Dr. Colson, who practice in Idaho, often proudly say the things he said when he stood up here, that he practices full spectrum care in this state. Kids, adults, and pregnant moms, all of it. He's proud of that. That's why he's here. He can do that here. He should do that here. When you sever 30% of what a physician's training allows them to do that they're passionate about, love, care about, the job is just a lot less appealing. And as those docs don't go to those rural communities, we can anticipate impacts on primary care access for children and adults. The cause for these provider workforce challenges, which are threatening this entire system of care, is fear and a lack of clarity in the language of the law. The law is ambiguous on the circumstances in which a physician is allowed to act. The law casts the issue of life and death as if it were a black and white binary thing. Those of us who manage life and death know that those are the poles on a spectrum, and in between lies health. And I would suggest that every man and woman on the street knows that bad health leads to death and good health preserves life. And we are trained to move upstream in that to preserve life by preserving health. What the system of care needs at this moment to stop digging the hole deeper, as Susie pointed out, is exactly two things. Number one, a belief that there is a leadership understanding that this actually is a real problem. No alternative facts. This is a real problem. We're seeing this happen. And number two, the belief by the physicians and providers that through their leaving are destabilizing the system, that action will be taken to clarify this law and create a maternal health exception. The cure for the fear is that belief, and removing that fear can stop digging the hole. Thank you.
Thank you, Dr. Souza. Last week, March 28th, marked 1 year since one of our small critical access hospitals' board of directors had to make an agonizing decision about ending their labor and delivery services. Brad Turpin is the CEO of Valor Health in Emmett, and he had to weigh a number of factors, including workforce, as well as the financial challenges in making that recommendation to his board. Brad?
First of all, good morning, everyone. My name is Brad Turpin. I'm the CEO at Valor Health in Emmett, Idaho. In addition to being a county-owned critical access healthcare system, we are one of the largest organizations in the county, employing over 200 people and putting about $6 million a year back into the pockets of Jim County residents. Before I share my story, I want to thank you for being here and listening. I think you've heard a lot of compelling information, but especially to those elected leaders who took time out of your day to be here. For those of us who are out in the field trying to take care of our communities, we really appreciate you at least being open and listening. On March 29th, 2023, we made national news. I got a text from my brother saying, "What is going on?" We announced the closure of our labor and delivery unit after delivering Jim County babies for almost 50 years. The process that led up to the decision, it was years in the making and heart-wrenching for all those involved, and I would argue still very, very emotional. It came down to two primary factors. First, the inability to staff our program consistently, and choosing the survival of the hospital and a commitment to serve the community and other necessary, well-utilized services over that one service. And although we are county-owned, we're proud that we don't take a single penny in tax dollars from Jim County residents. We support over 75,000 annual patient encounters across numerous service lines, 90% of those happening in the outpatient realm that don't require hospitalization. Operating margins in rural healthcare are razor thin across the country. It's no different for us. Despite financial challenges, we remained committed to our labor and delivery program for decades, all while it was losing about $1 million a year, just knowing how valuable that service was to the community. We established new service lines to generate profit, keeping us afloat and supporting the losses in labor delivery. In 2018, we assessed the low utilization of our program, averaging less than 80 births per year, the cost, the risk, and other challenges associated with the program. Almost 70% of our moms in our community were already choosing to deliver babies at larger Treasure Valley hospitals that have dedicated obstetric nurses and direct access to neonatal care. However, you're hearing some of the challenges now that they're having as well. Despite the limited number of deliveries, we increased our commitment to making further investments in the program, hiring an additional physician, and betting on growth that could help the program decrease its reliance on other programs to cover its costs. In 2022, we delivered only 78 babies at a total program cost of over $1.5 million. Medicaid provided the coverage for 48 of those babies, and for deliveries that cost us $19,000 to provide, we were reimbursed $7,500. During that time, we were forced to use traveling nurses to keep the service open at about 300% of typical staffing costs. In the first 5 months of fiscal year 2023, we lost multiple millions of dollars. We were 8 months from burning through the entirety of our cash reserves and being another story about a rural hospital closing its doors, unless we made significant changes. Although our financial changes were significant, our final decision to close the service came down to a lack of available staffing to keep our doors open. Labor and delivery requires significant investment in ongoing fixed operating costs. Not only do you need to hire and pay well-trained physicians, Dr. Colson is a great example, you need to do the same for obstetric nurses, anesthesiology specialists, and operating room staff. Many people don't realize you do not deliver babies without 24-hour day staff service available, including the ability to go C-section at a moment's notice. These are massive infrastructure costs, not to mention the efforts needed to maintain training and competence, as well as the costs associated with liability coverage. We had many months of intermittent divert in 2022 and 2023. For those of you who don't know, divert is basically when we say, sorry, we're closed. So if you're a mom that week, we can't deliver your baby. Maybe the next week, we can deliver your baby. That is no way to have a labor delivery service. Inconsistency is not a way to provide labor delivery in a community. We either do it or we do not do it. When we made the decision, there were a number of key workforce factors contributing to the inconsistent staffing. First, nurses in the critical access environment must be able to work the medical surgical floor and the emergency department, in addition to providing labor delivery nursing. It's inefficient to staff in any other way and wasteful. For years, we struggled to find nurses who were trained in obstetrics and interested in learning OB. Many nurses who became interested in OB left our organization to work in dedicated labor delivery units in larger hospitals where they were involved in multiple births per day rather than 1 to 2 per week if they happened to be on shift at the right time. We invested in partnerships with other facilities and internal training programs to keep our staff's comfort and proficiency at the necessary level. Ultimately, we were forced to hire traveling nurses to cover shifts at upwards of 300% of our normal staffing costs, just to keep the service available. In addition to the L&D nursing team, the program needs a full complement of operating room nurses and staff, as well as anesthesiology providers, all willing to take call 24/7 and ready to return to the hospital in the middle of the night if needed. We struggled to maintain adequate staffing levels with OR nurses and scrub techs, turning to a contractor to ensure we could adequately staff the program. Additionally, we struggled to recruit physicians, and we have a system of full spectrum family practice physicians who are interested in labor and delivery and trained in surgical obstetrics to provide C-sections in an environment where they would have a couple handfuls of deliveries a year. With the retirement of a key physician, every day of the year was being covered by only 2 physicians. Closing labor and delivery was excruciating, and the decision still ripples through our organization, our medical staff, and our community. Plain and simple, it has made it more difficult for women in Jim County to deliver their babies. We continue to provide prenatal and postnatal care, but delivering a baby at a different facility has impacted people. A key phrase in our mission, to improve the wellness of all generations today and into the future, captures our motivation and responsibility to be good stewards and ensure we stay open to serve our community. In an ideal world, payments for providing labor delivery services cover the costs to operate the program, and all the staff needed to stay open are available. Unfortunately, in reality, that's not the case. Again, I thank you for your time today. I welcome anyone who'd like to come and visit Valor Health, or if you have a critical access hospital in your part of the state, I encourage you to go take and visit them. I have some wonderful colleagues out there, and I think you could get a lot of insight. Thank you.
Thank you. I know we're getting short on time. We understand there's floor time coming up. We have one other speaker, and then Ken McClure and Brian and I will do a quick wrap up to get everybody out of here. But I'm very pleased and grateful to introduce Norm Barron, who is the Government Relations Director for Pacific Source. And in that role, Norm works to support review, implementation, and compliance with Idaho state and federal laws. And he has more than 20 years of experience in all aspects of underwriting and actuarial activities. So, Norm, thanks for being with us.
Thanks, Susie. It's fun when you know you're the next speaker and the room clears. We're excited to hear you. I am a lobbyist currently, but I've done a lot in insurance for over 30 years. Just a little bit short about how this is impacting, I think, healthcare from the insurance perspective. Insurance in Idaho is a little bit different. Most of the insurance in Idaho is done on a not-for-profit basis, which means all the dollars stay here and take care of patient care. But we're seeing a transformation. A long time ago, we would want to protect those members' premiums by saying no to unnecessary care and limiting things. But that transformation now is moving to more of a yes. And I didn't work with Brian on this, but we want to provide the right care at the right time and the right place. And it's really important. That transformation is taking time, and we're in the middle of that. But overall, as you've already heard, Idaho is underserved with physicians in general. And when it gets to specialty care, the challenges are even greater. We've seen an out-migration and a lack of in-migration of physicians in this space. And where that gets very challenging is the overall care that they provide in certain circumstances. And today, that's women's health care. If we're striving for the right care, the right place, and the right time, then the availability of physicians and clinicians with expertise to treat those conditions is paramount. What I've learned through this process is a good example. In an OB practice, you need, at a minimum, 3 OBs. Why do you need 3 OBs? Because babies don't come 9 to 5. And you need to make sure you have the coverage for those conditions and those children as they're being born. One might argue that a woman can travel to get the reproductive health needs met. However, it is likely that she has great needs, and traveling for those needs because of a shortage of providers is not effective health care. That's a really important statement because I can give you a little bit of a personal example. I'm a husband, and I'm a father of 3 now grown young adult women. Very proud of them. Over a year ago, my middle daughter showed up at our house with her husband and said she was pregnant. And boy, were we excited. And I'm not making this up. The next day, she got very, very sick and moved in with us for 8 months until she had a baby. Now I could show you the baby because I have tons of pictures, and she's the most beautiful little girl you've ever seen. But now I'm a grandfather, and I have another little beautiful woman in my life. But I want to point out, her traveling, she couldn't travel. She got a lot of home care, she got infusions, she had a midwife, she had an OB, she had a lot of care. But if we lose some of that care, I'm not sure she would have had that good outcome. And I can tell you, she could not have traveled. She could not have gone extensively anywhere to get the care that she needed. So from the insurance perspective, we're trying to make sure we provide that right care, right time, right place. And we need to have the provider community that we can rely upon to do that care.
So overall, to have that best health care for our members, we hope that any barriers or restrictions can be reviewed to ensure that they don't inhibit the ability for women to receive the health care they need. So with that, thank you for your time.
Okay, and now we will have Ken McClure give us a quick overview of the current legal status of Idaho's law. Ken is a partner at Gibbons Pursley and has been the lobbyist for the Idaho Medical Association for 3 decades. A long time. Thank you.
Good morning. Very, very briefly, I want to address the current status of the litigation concerning the total abortion ban, which is the statute in Idaho that says you cannot perform an abortion except to prevent the death of the mother. As you probably know, that case was, that statute was put on hold by Judge Windmill, federal Judge Windmill. His decision has been appealed, and in a very unusual process, the case was taken from the Ninth Circuit by the U.S. Supreme Court without having a circuit decision on the matter. And that case is set to be argued 3 weeks from today in the U.S. Supreme Court. If they act as they typically do, you should expect a decision on that case by the end of June. But that doesn't end the concern about Idaho's statute. Regardless of how that case is decided, we will still need some clarity in Idaho's law to provide the comfort to Idaho physicians who are faced with difficult choices on how to treat a woman who has pregnancy complications. The case before the Supreme Court is essentially who has the right to make the decision. We learn in law school that federal law preempts state law when federal law and state law are inconsistent. That's the question before the court now. Is there an inconsistency between federal law and state law? State law says you may not perform an abortion. Federal law says if you work in a hospital that participates in the Medicare system, you must provide stabilizing care for a patient, not only to prevent her death, but to prevent serious impairment of her health or serious impairment of a major organ system. So the real question between the court is, state law says health and you cannot intervene, state law says prevent the death and you cannot intervene to save her health. Federal law says you must intervene and save her health. So regardless of whether the court says the federal law does preempt state law, or whether the court says federal law does not preempt state law, there is still clarity that will be needed concerning how and where and when the care can be provided. The federal law applies only to emergency care in a hospital with an emergency room and to a patient who presents there. For anyone who's followed healthcare for the last little while, you know that that's the latest and worst and most expensive place to obtain healthcare. And so driving women who have healthcare emergencies and making them wait until those emergencies become life-threatening is simply not good for any of us. And that's the case. So regardless of where we have a decision in June, regardless of what that decision is, we will need clarity about how to provide the right care at the right time. Thank you.
Thank you, Ken. So we'll go ahead and wrap up. As you've heard, regardless of what happens with the U.S. Supreme Court, Idaho still needs a maternal health exception to our abortion ban. It will bring clarity to the legal environment for treating these pregnancy complications. It will reduce uncertainty and fear amongst physicians and patients as well. It will help stabilize our workforce, and it will help with recruitment of new providers into the state of Idaho. Again, thank you all so very much for being here. I know most legislators have had to go. Thank you, Representative Roberts, and Representative Green. We very much appreciate the attention of the legislature to this matter, and we look forward to continuing to tell the stories and push for change.
Thank you, Susie, and thanks to everyone who's participated today. It's been great information and hopefully helpful information to those that have to shape the policy of the state of Idaho. As hospitals, we go out into our communities and we do what's called a community needs assessment. We find out what's on the minds of legislators, constituents, and the patients that we serve in each of those communities. And we have 3 recurring themes that come back in each of those community needs assessments across the state. Idahoans want to make sure that we address the lengthy waits to get in to see even a primary care doctor. That's top of mind for them. When they pick up the phone, they're feeling sick and they want to get in and see somebody, they're finding out that they have to wait. They want us to address that. Second, they want us to address the trouble in scheduling urgent appointments. I'm feeling really, really sick and need to get in to see somebody. And they're finding out that they have to wait sometimes weeks and months to get in to see a specialist. And they want us to address the difficulty that they're having in finding specialty care, especially women's reproductive health care. And hopefully the information that we've provided today sheds greater light on that situation and why it is so critically important that we address this issue and make sure that we not only have the healthcare workforce in place to address the needs of women's reproductive health, but we also have the ability for those women to access that care when it's needed. So thank you again for being here. I'll turn it back to Susie if you want to wrap up. Most of our legislators have had to go back onto the floor. We appreciate the fact that they spend a good portion of an hour with us. And again, we appreciate the information that all of you have not only shared, but the stories that you brought with you today. So with that, thank you for being here, and we look forward to continuing this conversation and continuing to make progress in doing what's right for Idaho.